Dr. Lanier grew up in Houston, Texas. He briefly had hair. He went to medical school and did a lot of training, which he completed in 2014. He has been practicing in the CICU for 10 years at CCMC. This is what Dr. Lanier suggested I say about him. And the contrast between what he suggested and what I'd rather say tells you much about Dr. Lanier. Lane is one of the best physicians at Cook Children's. We have a lot of good physicians at Cook Children's, and Lane is one of the best. And I feel especially authoritative on commenting on his skill, as Lane and I are both pediatric cardiac intensivists. In addition to being one of the best clinicians I know, Lane is one of the best teachers I know. He's won teaching awards at each and every level of his training and practice. He didn't give me his CV, but I have your CV because you're a investigator, so I can go look at your CV. At every level of training, he is given the teaching award. And if that's not enough, he's also one of our best researchers. He is effusive in idea generation, a consistent mentor for research trainees, and he presents nationally. Please welcome the much too humble Dr. Lane Lanier.
All right, can everyone hear me? That's good. All right, we're on. Fantastic. Wow, that was was not prepared for that. Thanks, Will. That's very kind. This has been a wonderful conference. I have really enjoyed the challenge of trying to understand different fields and what's happening all over. You know, sometimes as growth occurs, sometimes the right hand doesn't know what the left hand is doing. And it's symposiums like this that brings this together, not only within Cook Children's, but within our region. Within the state and nationally. And so, wow, I'm appreciative that you have decided to spend the time here. And I hope not to disappoint you because, boy, these talks have been fantastic. The challenges that people have undergone, the challenges that have been overcome, and the preview of what is to come. It's exciting. And it's an exciting time to be here at Cook Children's Medical Center. I am a consultant with Edwards Life Sciences and do some teaching. So I want to discuss some ways that biotechnology has impacted the cardiac ICU here at Cook Children's Medical Center. I want to identify one of the big challenges and offer an invitation for those of you who want to come and help me with real-time continuous physiologic data. And then I'm going to discuss how we can leverage our strengths to further innovate within the cardiac ICU and more broadly at Cook Children's. So I am going to start with a quote. Teach us to number our days aright so that we may gain a heart of wisdom. Does anybody know where that quote is? Yeah, it's a psalm. It's a psalm from the Bible. It's Psalm 90, the Psalm of Moses. And so, as I was thinking about innovation, this kept poking into my mind. So, how is that relevant to us as clinicians? We have to realize that we have a finite period of time to impact our patients. I don't see this talked about in training very often, but as we're trained, as we go out, we are concerned about making sure that I am doing everything I can do to save the patient in front of me. I want to get that patient home. I want them to do the things they want to do. I want them to go run and play and do the things they want to do. That's kind of how my goal was. And I want to know everything there is to know so that I don't ever have a problem and I can send that patient out and no one dies on my watch. But no one talks about, well, your career, really, when you get out of training, is pretty compact. How do we have to first realize that we only have a fixed amount of period of time, a finite period of time to make an impact on the patient. And I think understanding that will allow us to identify problems and will allow us to innovate. But I think that mindset is key. Because when we innovate, we're going to identify, when we realize that we have a finite period to treat those patients, we're going to start identifying problems and we're going to start thinking. I know this is a silly 1980s reference, but I think about MacGyver. All right? MacGyver was a TV show, and this guy was always put in situations where he had nothing at his disposal except some liquid ball bearings, a piece of gum, and some broken down tool, and he could create a bomb in 5 seconds. And it was amazing. But you talk about innovation, you talk about what he was able to do, it was impressive, and his life was on the line at all these time periods every week around 8 p.m. And so I know it's a silly analogy, but realizing, a problem and identifying that is key. And so we all have something to bring to the table. Today, I'd like to show you how our group recognized a problem, how we innovated, how we were innovative in our space without a whole lot at our fingertips, and how we affected clinical change. And then I'm going to talk about some other issues, something that we're dealing with now and something to come. But I want to make this point. You don't have to be the one to develop a $1 million drug. You don't have to build a machine that can alter the outlook for a patient. You have so many things at your disposal here already that you can utilize. So with that in mind, let's go ahead and talk about a problem, all right? So I am not a neuroscientist, all right? Dr. Perry will tell you I just don't have the brains for it. But I am not. And so we are going to go a little bit more inferior today, down to the thorax, all right? So pleural effusions are something in the cardiac ICU that we deal with daily, all right? So again, the lung is surrounded by this pleura. The pleura is a potential space, and so when there is multiple different pathologies, we can get accumulation of blood. We can get accumulation of serous fluid, think kind of straw-like thin liquid, or we can have fatty contents in there, this chylous fluid that we have. Different pathologies, but the same problem persists, is that the lung's unable to expand. As you can see here, the lung's unable to expand because there's fluid between the chest wall and the lung. So in these patients, and in patients where we develop air in that space, called the pneumothorax, we have an issue. And that issue is that the patient we need to deliver oxygen to the tissues. If I've got a lung that's not opening, that's going to be a problem. And we're not going to be effective in that. Now, throw on top of that a heart that may not have the best cardiac output. Again, my job, simply stated, is to deliver oxygen to the tissues and do everything I can to make sure that happens. Deliver appropriate perfusion pressures to the brain. I've got to make sure all these things work. And so this presents a problem for me. So we need to put a chest tube in. And that's something we do quite routinely in the cardiac ICU, okay? So when we put a chest tube in, you can see, same patient, you can see immediate results. How wonderful is it to do something quickly and see an immediate result in the patient? Oh, that doesn't happen all the time. So we're able to put in a chest tube into the pleural space. Now that will take some sedation for the baby, because this baby does not have an endotracheal tube. Just so you know, I can kind of orient other people. This is a feeding tube down the patient. This is external to the patient. And these are sternal wires after cardiac surgery, okay? So the lung, you can see, is well expanded. So our standard of care is to suture our chest tubes at the skin, and we do that. So we suture our chest tubes at the skin, and you can imagine a patient who now has 2 lungs, that a patient is going to feel better after that. So here's problems that we see in our cardiac ICU. The baby's better. I've found, and I don't know if there's a publication on this or not, that parents like to hold their babies. Parents want to hold their children, especially when they're in a critically ill state. They want to hug their children. They realize that they may lose their child. So parents will hold their children. We'll transport that child to the parent. That's an opportunity for that chest tube to become dislodged. We weigh patients in our cardiac ICU. We lift them up. If that chest tube, if we're not watching, that chest tube can come dislodged. Every 18-month-old or 2-year-old will find their fist around their chest tube and remove it if you're not careful. And that can happen. What happens with that? Well, the chest tube becomes dislodged. And what happens when that chest tube becomes dislodged sometimes is that we have recurrence of said pleural effusion, hemothorax, chylothorax, pneumothorax, etc. So what, Lane? Put a chest tube back in. Big deal. Just get it done. The heart and lungs are kind of married together. And when you have a patient who has suboptimal cardiac output, giving them more sedation is not always fun. They could have hemodynamic compromise. They could have a cardiac arrest if you're not careful. The patient may end up intubated if you sedate them too much. So when we lose a chest tube, it's a big deal on a patient. It may set them back in their course a few days. So they have longer time in the cardiac ICU. That may lead to more infections with invasive lines. So we want to mitigate this process before it begins. So we're suturing these chest tubes as a standard of care. Now enter Dr. Jay Duncan. He's the medical director of the CICU. If you don't know him, you should introduce yourself to him. He's a good guy. So he's a very bright guy. He was looking one day and noticing, man, we are using subcutaneous securement devices on our peripherally inserted central catheters, our PICC lines, okay? We're using these subcutaneous anchor securement systems. And I wonder, can we not just use those to place our chest tubes? I mean, why do we have to poke the kid and suture in? And would there be benefit to that? So that question arose out of necessity. We were seeing a decent amount of displaced chest tubes. We were even seeing some bleeding around chest tube sites. Remember, a lot of our patients are on anticoagulation. So again, the subcutaneous anchor securement systems can be added onto any round shaft catheter ranging from 2.6 to 12.5 French. So 2.6 is a very small peripherally inserted central catheter. 12.5 French is quite large. We place chest tubes with 8.5 French, so we fit well within this category. There's no adhesives needed for securement. Anybody ever have a patient who had skin reactions to adhesives? It's a problem. No sutures or additional punctures are needed. It remains in place of the catheter. So if you can see, it's a little tough to see, but these little feet that come out underneath the skin allow about a decent amount of pressure per square inch to be utilized to actually have to remove that through the skin. It holds up nicely. You can lift the baby up and it'll pull and stay in place. It's impressive. So we thought about, should we go ahead and trial these? And so Dr. Duncan was able to do that. He talked with the device company, it was FDA approved, and then he was the one who began starting to use these. I was a little hesitant. I said, I don't know, but boy, I was like, this is interesting. I'm going to show you the removal of this device quickly on one of our patients in the cardiac ICU. So this is an extubated patient, so they're breathing on some high flow cannula. And remember, babies like to move. They don't care what you're doing. They want to move. So I can give them sedation, especially if I'm going to be cutting out a sutured chest tube, or I can remove this device. And remember, if I'm cutting something, I've got some sharp objects right near the skin with a moving target. This is the removal of our device. So you're going to see how the device works. You like the music? Yes. So we have our device here. There's a two-pronged approach. There's a cover to it and something underneath that's anchoring it. So I'm going to lift that up here and take that away from the patient. Patient protests a little bit. You can see how the chest tube fits nicely inside there. And then we're going to fold that down. The feet now are aligned with the opening to the skin. And then you can cleanly remove that. Again, there is no need for any scalpels, any kind of scissors, anything sharp near the skin. And we're done. Now we just pull the chest tube out and we're finished. No sedation for these patients. So we said, okay, this is good. People are seeing that it's good. Do we have the data to back it up that it's appropriate? So we first of all had a hypothesis say, is this safe? Number one, we've got to prove that it's safe. And then number two, is it better than our standard of care? We've had patients, have their chest tubes inadvertently removed, et cetera. So we designed a study to look back retrospectively over a few years, and we found 140 patients. Now, patients need multiple chest tubes for multiple different reasons. So we had 204 chest tubes placed, 64 were sutured, 140 used the securement device. There was no significant differences in the patient population in our cardiac ICU. Some patients here, different types of cardiac surgeries, typically have more effusions related with them. We wanted to make sure that we took a look at that. And the other thing that we wanted to do is, okay, within these two groups, did one group have their chest tubes longer, leading them to be inclined to have more complications? That wasn't the case. There was no statistical significance between the two groups. But our results were interesting. So again, you'll look at our complication rate with just suture. And our complication rate, 5, complications being bleeding, infection, and inadvertent removal. Again, retrospective study, we're probably missing some data here, but we found that this was impressive. And so we made a change in the cardiac ICU based upon somebody having an idea, somebody going through the appropriate processes of finding ways to implement that idea into our practice, and then studying that idea. This is not something where we had to go and work with drug development. We have seen how we are streamlining that approach here, and those are amazing things. But if you're looking for innovation, you've got ideas. You have a perspective that no one else has in your area. You have experience. And you will find these ideas, and you will find solutions to those ideas. And there's a way and a process, and we have tons of people here to help you move that idea to clinical change. It's impressive. So now, all of our patients are now undergoing securement device placement. And we don't see anymore, we haven't seen since this implementation, any more issues with inadvertent removal, bleeding around the chest tube site, infection. So I want to step and pivot away, and now I want to talk about something that we're utilizing here. It's kind of exciting in many different facets. This is a platform that we have in the cardiac ICU that gives us real-time physiologic data. So as it's happening to the patient, it is being downloaded here. So I'm going to kind of walk you through this slide to show you some of the complexities that we have with this. And I want to talk a little bit about the benefits. So here, I'll just call it the y-axis here. We have heart rate at the very top, that green line coming across. You can see the heart rate variability, beat to beat, minute to minute. The SpO2 level is there. You've got your systolic, mean, and diastolic pressures. The LAP, this is our intracardiac pressure. For that, we can monitor if our surgeon places an intracardiac line in our patients after surgery. Those pressures are quite telling about what's going on, and it's very helpful to us as CICU physicians in the immediate postoperative period. So monitoring that is key. As we come down here, we've got oximetry levels. So we have cerebral oximetry levels, which give us a kind of trend about how the patient's utilizing oxygen, extraction of oxygen, cardiac, it can be a surrogate for cardiac output as well. So we place those on the head and on the renal, and we could see those move. This patient is a patient with hypoplastic left heart syndrome, which is a very complex cardiac disease. And the first surgery is it's a very involved surgery, and it has to be done well. There can't be wasted time in the OR with this. We have very good outcomes here because we have a very, very good CVOR team and perfusion team. And so when those patients come out to us, those patients are they're bleeding, they're very sick, there's a big change to their cardiac physiology, and we need to know exactly what's going on with them. The more data that we have, the better, so that we can institute change, and the quicker we have that data, the better. So we're watching these patients, but these patients aren't in a silo. We also have other patients within our cardiac ICU. So as I see patients have changes, it can be quite significant. You can see here, just looking backwards, you can see here at 2100 on this night, this patient started having decreases in their oximetry levels. Their intracardiac pressures started rising. This patient was having a pulmonary hypertensive crisis. And so you can see the SpO2 levels up there drop significantly. We saw this in real time. Sometimes we have nurses doing other things. Sometimes the nurses are paired. This allows us to understand what's happening. And we may see something before the bedside nurse sees it. I want to draw your attention to the top line. You'll see this green and red graph here. This is an algorithm for the company that provides this platform to us. They designed this. We are watching something called the SVO2. That's the amount of mixed blood coming back to the heart. And looking at the oxygen levels within that blood, it can tell us about cardiac output. It can tell us about how the baby's extracting oxygen, et cetera. This company has developed something called the IDO2 that mimics the SVO2. And they have a predictive algorithm that will allow us to understand when that patient has a high likelihood of having an SVO2 less than 40, which would mean that the patient, there's something clinically going on. That should bring me to the bedside and investigate. And the higher the red on that graph and the less green you see means that that likelihood is nearing 100%. So in the midst of this patient having this issue, if you walk up here at 2100, you can see that algorithm screaming, something is amiss. To me, that says, get to the bedside and examine that patient immediately, even before the patient is in extremis. Maybe it's not recognized by the nurse. Maybe I'm doing an admit over here, but I need to be monitoring this. This can help me as a clinician inside my cardiac ICU. Well, how so? Well, do you have a place where you can do that? Are you walking around with a computer? Is there a home base where this data is projected? Yes, there is. And so within our cardiac ICU physician room, you can see here every patient in the cardiac ICU, and you can see a screenshot. And you can see their IDO 240, and you can look at other parameters for their cardiac output, et cetera. This has been very helpful as you have a busy unit. Then we have what we typically have, telemetry over here to the right, so we can monitor even two different patients. This is an interactive screen, by the way. We can go up and touch, move to a certain patient, change parameters, time, everything. And it's wonderful. I enlarged it over here so you could see it. Again, very good. So here's the problem. I'm busy. There are so many patients. I'm getting so much data that sometimes I don't understand fully what I should be doing. Now, what's been wonderful about this conference is that we've had a number of people talk about how their institutions, and even our institution here, can help us synthesize large swaths of data. So here's my plea. I need your help. I need your help because I hope you can see how much data is coming at me. If you'll look over here, these are the different variables that I have. Notice that I've got a whole nother column down below. I have so much data coming at me. What does that mean for me right now? What does that mean for the patient in real time? Can we develop something to kind of allow me to know, hey, within this certain type of congenital heart disease and this certain type of operation that the baby's undergoing, what can I expect given the data that we have on the patients in the past? What can I predict may happen to this patient with certain variables at certain levels? This would be fantastic if I had really good data that would change what I do minute to minute. This is fantastic. This also has benefited us in another way. Despite our best here at Cook Children's, and we do a very good job here at Cook Children's, and we have data to demonstrate that with taking care of patients with congenital heart disease, patients have untoward outcomes. They can have an arrest. Patients can die. Their cardiac physiology may not be compatible with life, despite our best for them. We were able to look back minute to minute and to see where we can change things. So our morbidity and mortality conferences have been more robust. We're able to see what's happening in the patient. Oh, hey, look at 2103. Did you see this drop here? Did you see this change here? I don't know. I don't know if I saw that. It was so quick. Go back on telemetry and we could see that patient may have had a salvo of an abnormal rhythm or something that we just didn't pick up. Or we may see other signs with this data saying, hey, all these things were trending downward. That's interesting. So this data set has been very helpful to us, but we're not utilizing it in ways, I think there's just so much that can come from this. We have so much at our fingertips. We just need to be able to synthesize this data and develop some predictive algorithms, which I think will be very beneficial to our patients. So, for those of you who have a handle on machine learning, who go to sleep and that's all you think about, come talk to me. Those of you who have expertise in artificial intelligence, I would love, we are rich in data, but we as clinicians need help on how to put that into practice. So I implore you, come find me. All right. Okay, blood pressure monitoring. Blood pressure is pretty important to me as a cardiac ICU physician. I want it, and I want it continuous. So I want, hey, yeah, look at that kid, I think we're doing okay. Well, let's get an art line in that child. Patients come back from the operating room with arterial lines. But as you know, arterial lines are invasive. Arterial lines can create problems if left in too long. This is what an arterial line should look like. All right, this is beautiful. Our nurses have done a great job in caring for this. We have people specific in our unit to go by and to look at lines, to redress lines, looking for pressure injury, looking for areas of infection, looking for breakdown. Very important. But sometimes, there we go. Sometimes problems can arise with arterial lines. Infection finds its way. We break the skin barrier, infection finds a way. Now, arterial lines these aren't the lines that typically cause our infections. Those are usually peripheral and inserted central catheters, but arterial lines can be a nidus for infection in the infant. Unfortunately, despite removal of this arterial line, after seeing this quick and abrupt change, this patient succumb to their injury and to their pathology. It can cost. But we need to be able to monitor our blood pressures on our patients and to have appropriate monitoring. So, what's to come? Technology. Technology that's new. Technology that is making its way. Technology that has been evaluated by multiple studies. We have a non-invasive continuous blood pressure monitor that's FDA approved right now for 12 years old and up. This is non-invasive. It has oscillations around the finger of the patient and provides pretty good data. The adults have this. It's been studied, as you can imagine, quite well, but as you pull it down to smaller individuals, you can imagine that gets a little bit more difficult. You want things to move. Things are stiff. The design has to be appropriate. But this will hook up to monitoring and has been studied in children who are 6 years and above. It's been studied in electrophysiology laboratories. It's been studied in the pediatric ICUs. And it's found to have a pretty good correlation with arterial lines. So can we mitigate some of the problems we have with arterial lines if we're not needing arterial blood gases by transitioning to something that's non-invasive? I hope so. I hope so. And we have these opportunities to use them. So here's a look at the cuff on a 12-year-old right now. You can see that it just fits across. This folds, comes back and folds over, and then the cord would hook up to a long cord up into the monitor. This would actually be transmitted immediately into the platform that I showed earlier that we're using for continuous physiologic monitoring, which would pair nicely. So there's opportunity to evaluate this. And so one of the best places to do that, I think, would be the electrophysiology lab. The arterial line is not being used for drawing blood gases. We're going to correlate, coming to the IRB near you, we're going to be correlating a non-invasive cuff with invasive arterial monitoring to make sure that the data that's been published is actually true on our patients here at Cook Children's. We have a number of patients. We have a very busy EP lab, and I think that's a great place to start. But let's not stop there, right? This is the symposium where we're thinking big ideas across the health system and beyond. What about in the cardiac ICU for my patients? Can I transition them quicker? What about the pediatric ICU? What about the emergency department when a patient comes in and the ED physicians are trying to make a decision on, is that cuff real? Is it not? The perfusion's not so great. I'm concerned and I can't get a good blood pressure. What if we had something beat to beat on the hand of certain individuals coming to an emergency department near you? What about our infusion clinics? How many times have you heard a rapid response team have to go to an infusion clinic? What if the nurses there were able to have something where they could put on a patient while the team arrived, so that as pediatric ICU doctors, when you arrive, I've got 5 minutes now or 3 minutes of continuous data to make a decision now on the patient. I'm not walking into that situation blind. These are ways that we can evaluate, studies that we can perform, I think, quickly to make our institution better. Dialysis clinics are the same way. Okay. Finally, how do we leverage our strengths to innovate? As I thought about this, I really couldn't overcome the notion that we have so many strengths, but I think the strongest variable that we have here is you all. That we have people who have trained at different institutions, who are coming here, who are sitting here in this audience, and they're ready to learn, they're hungry. We have a student base across TCU, A&M, UNT, I mean, everywhere. We have all these students who are hungry to learn and to work. And they want, you know what they're seeking? They're seeking mentorship. So when you sit there and you say, I don't know that I have anything to offer, just wait 5 minutes. Interact with them. And I'm telling you, they will ask you questions, and they will want to know more about what you are doing. And this is just my day-to-day, but they don't know that. So when we see this, we partner with our students. We partner with our students in projects, and I am telling you, my projects have taken off. Why? Because I have good students who are willing to work hard, and you know what they're going to do? They're going to find my blind spot. Do you know how many times that we sit down in a room together and the student asks a question that I had not completely thought out? I'm like, yes, we have to cover that. If we're going to present that nationally, that has to be something that we know. And the student has brought that up. And I'm like, that's a great idea. Or maybe they want to modify something. It's fantastic. We have a rich resource of students who can help us. And you will definitely be of help to them. They are hungry. Our securement device was presented at SCCM. That is in preparation for submission. The two students did a fantastic job on it. They not only got to see what a national conference was like, they got to see their work projected, and they got to see people asking questions about it. And they were actually able to answer some of the questions to pediatric critical care physicians. In addition to this, they also got to see industry and how industry was trying to interact with academia. It was and they came away just, again, much more knowledgeable than when they left, but curious. This is what we have here. Finally, I would be remiss if I didn't mention Chris and Fidike. The support that they give me, the kick in the pants sometimes that they give me is fantastic. And these individuals have been a huge, huge help. I cannot overstate that. To me, growing. When we get down into the dirt of statistics and I'm misinterpreting something, do they take the rudder and move me back into the waterway. I am very grateful for them. What we have here is special. Please, please don't underestimate that. So let's end where we began. Teach us to number our days aright so that we may gain a heart of wisdom. We have a relatively small period of time to benefit our patients. 10 years for me here has gone super fast, and it's moving faster. You have a small amount of time. Think on that, because in that, you'll be able to identify problems. You'll be able to work with others, and you'll gain wisdom, and you will innovate. Remember, everything for the child. Thank you.
That's an excellent talk. I would like to ask you questions about like all the signals you saw in the intensive care unit about describing the activity of the heart. So, and you said like you need help there, and and you have plenty of data. I can see that. So, how we can help you? Like how somebody who's in biomedical engineering can help you in your profession to put all things together in an AI system or something like that and provide you with a decision or something, or a suggestion?
Sure. So there's a lot of heterogeneity within cardiac disease. So multiple different surgeries for different types of cardiac substrate. So if we know that we have a certain type of substrate with a certain surgery happening, looking at those patients with the data we have, we just onboarded this within the last 6 months or so. And so this is relatively new technology for us. Again, trying to maneuver our ways. But if I can look at and grow patients and seeing how they're responding over periods of time, because all this is kept, this data is kept here at Cook. And so can we look at what those patients have done in the past and when those patients have had issues?
To predict. Yeah.
Exactly. Yeah. So, but again, I don't have that expertise, and so having somebody come alongside and us using my expertise with their expertise, I think could help us to even as you get more numbers, right? You'll refine that and move along. But I think I need somebody to help me because this is a plethora of knowledge, and this is not even half of the data.
No, I can imagine. Like, yeah, I just try to identify like kind of a problem from your side and how we can contribute. There's billions of tools that can help you in this kind of work.
Yes, sir.
Let's talk more about that.
Yes, sir.
Yes. Thank you.
Well, I mean, Christos, maybe talk a little bit about, so in these courses of treatment, post-operatively, there's going to be several clinical decisions that are made, and a lot of times those are made with objectivity, but a lot of subjectivity to it. So is the kid ready to extubate, for example? Is he awake enough? Is his hemodynamics look well enough? You take all that data, and guaranteed there's stuff that we don't know about the kids who fail versus the kids who succeed, right? So extubation, post-operatively is one of those. Is it okay to close the chest if he's got an open chest? Big hemodynamic change. But then further out, some of these kids never eat.
Correct.
They've got feeding intolerance.
Absolutely.
Low cardiac output and swallowing problems. So can you tell us which of these variables?
Yeah, I have worked in the past with heart rate variability, like long time ago, and then there's multivariate autoregressive modeling techniques. Right. There's a lot of tools that like you can take information from all these variables in time series and then predict and gives you exactly what you said. Like, okay, so give a suggestion to the physician like that's the most important variable or not versus like to the other one or what can predict also. There's predictive tools. They're used in stock market, for example. Like, so there's a lot of tools that like you can use for making medical decisions, but also like for predicting like what may happen in the next hour or two. There's a lot of things that can be done in this project, like from an engineering point of view.
Yes, no, yeah. I agree. I think, and that's why I need help from people who understand that.
Sure.
As much. That's why my plea is to you.
Yeah,
come find me, because again, this is relatively new for us. We're just understanding what we have, and this isn't even complete yet. We're adding medications to this to run real time. We're going to have urine output associated with this real time coming out. So it's going to be, we're going to have a host of variables to look at. It's going to be, I'm really excited about it.
Great work.
Thank you.
Careful what you ask for, though. You may get HD EEG post-op in that two more lines on that.
Okay. I mean, he's leaving. He's running now.
It's it is. So the whole point of what all you're doing, right, is for the head, right? I mean, the whole point of this is to have good neurologic outcomes. And
Absolutely. Because again, the goal now isn't survival. In 1981, when we were doing the Norwood procedure, it was relatively new. The mortality rate was sky high. Fast forward 40-something years, now our mortality rate is very, very, very small. Now we're more interested in neurologic outcomes for our patients. So if you throw regular EEG data on top of this, it'd be interesting to see. I'm not asking for any kind of extra EEG. But to your point, yes, neurodevelopmental outcomes matter. And so Dr. Johnson's here. I hope she's here too, because that's a big deal. Go ahead.
Well, that's one of the, the secret sauce, I think, at Cook is we've got this expert clinicians in the ICU. You got expert clinicians in the OR. So you've got good surgical outcomes. You have expert clinicians in the ICU, so you have good post-op outcomes. And then we've got this entire system of follow-up, right? And so linking all those things. But so far, all this data has not, you don't get all the data from the OR. And the ICU doesn't give all the data to the floor. And the floor doesn't give all the data to Dr. Johnson. And so it's just, we're all accumulating it. And who knows what we're missing?
Agreed. We don't know a lot of times what we don't know.
No.
And so that's going to be interesting. Dr. Moore.
Thank you for your talk, and I have to completely agree with Dr. Segal in regards to your mentorship. The first time I met you, I think within 20 minutes I realized I was being mentored. So question 1 of 47 is, are you familiar with senior design projects at universities? That Texas A&M has, every year they have senior design projects.
No.
Okay. So, there's engineering students, AI programmers, and, I think there's a lot of data. I think there's a lot, that can be done here, obviously, and there. And they're always looking for something to do that's relevant and impactful, and they all have budgets. And so whether it be a mechanical device or an engineering project, and I've served as kind of a health mentor for them, if it has a health-related outcome, they'll seek someone on campus to pair with them. But then they have a year to either write code or create a device, and then they go through iterations, and then they get money and they build it, and then offer it. So that may be something too.
No, thank you.
Yeah.
Hi, hello. I'm really tall, so I'm going to squat. I'm Denise with A&M Innovation, and I hadn't met you, but we'll connect later. We're new in this region, A&M Fort Worth. I'm with System Innovation, and I work on this type of thing. Our priority in this region for A&M System is AI in medicine. So that's why I came to hear you, which I'm really excited. And Christos, we have a meeting with you at the end of the month, so nice to meet you in person. But I think that meeting topic might need to shift to this. William's shaking his head. Yes, so one of the things we want to do here as our focus is AI in medicine is to put together some AI and ML teams that is their only focus, and we're looking for the first problem. So we will be talking further, but I wanted to share this with everyone as an example that when you do presentations like this and you ask for help, amazing things can happen because you don't know who's also working on similar things in your space.
Oh, sure.
So thank you for this.
Yeah. All right. Thank you again. Is that good?
No, I got more.
Yeah, come on.
A minute. Okay, hang on. Okay, I'll exhort people as well. So, okay, the strengths you're showing here, right? You're evincing all these strengths. So, what are Cook's strengths? Well, we're big, right? Like we have a ton of patients. We've got this sort of singular focus on care, and that's actually the combination. This comes from a conversation I've had with Dr. Nedlow a few times about what actually is going on at Cook's is like expert phenotyping. That's at this point in your career, if you had stayed in academia. You would be down to 10 weeks of service a year, maybe less. If you're successful, if you stayed in your career.
Yeah, no. No, the point, I just had a discussion with Dr. Roy about this. I want to, and if I could, just mention this.
It's your talk.
I was in academia. I did everything I was asked to do. I was happy. Let's go get a T32. I'll get a T32. Let's do it. Let's get this grant. Let's do this and work in basic science. And I felt low. I didn't feel like I had anything to offer anybody. I'm just going to the vivarium, and I am the assassin for mice. and I'm moving things, and then I'd see things kind of culminate, but I was still developing this process of thinking. I felt when I came to cook that this, and I hate to use this word, but this yoke was heavy on me. It's developing presentations. You've got to do this, you've got to do that, you've got to do this, you've got to do that, and all these things, and we want you to be productive here. And I felt like I can just focus on caring for patients. And in that focus, in that time, my goodness, I was talking to Dr. Roy, I said, I'm swatting away ideas. Yeah. I'm just so appreciative to have that opportunity here, but I believe it's because of the culture of this place and allowing us to be expert phenotypes, as you mentioned, that has allowed me to grow some of these ideas. Go ahead, sorry.
Well, Tia is telling us to stop, so I will stop.
Okay.
But what the expert phenotyping does is it also gives you expert evaluation skills. And so you are better than your colleagues at being able to say, this technology, yes, that technology, no. So, how do you go about evaluating what you ought to do and not to do, right? A lot of that is experiential, and you have more experience here than you would have had elsewhere.
Because we don't separate from the bedside. Everything for the patient.
Thank you, Dr. Lanier.